Welcome to our video on renal tubular acidosis. Renal tubular acidosis is commonly referred to as RTA. By the end of this video, you are expected to be able to discuss the pathogenesis, diagnosis, and treatment for proximal and distal RTA. You are also expected to be able to differentiate renal versus extrarenal causes of normal anion gap metabolic acidosis, diagnose, and manage RTA. Just a quick review about serum anion gap before we discuss RTA. Our body is electrically neutral. Positive charges are equal to negative charges. Major cations in our body include sodium and cations that we do not routinely measure. Major anions include chloride, bicarbonate, and anions that we do not routinely measure. These two quantities are equal. Clinically, we do routinely measure sodium chloride and bicarbonate, so we rearrange the equation and put things that we measure on one side and things that we do not measure on the other side. This gives us the equation sodium minus chloride minus bicarbonate is equal to the difference between unmeasured anions and cations. The quantity sodium minus chloride minus bicarbonate gives us an estimate of the unmeasured difference between anions and cations. We define this quantity as serum anion gap, where serum anion gap can be calculated as serum sodium minus serum chloride minus serum bicarbonate. A normal anion gap ranges between 10 and 14 millimoles per liter. When we have a new acid that enters our body, denoted here as HA, the acid can dissociate into a proton H+ and an anion A-. The H+ uses up one bicarbonate, while the added anion increases the anion or the anion gap by 1. Acids that enter our body and can be detected as an increase in anion gap is called high anion gap metabolic acidosis. However, when metabolic acidosis occurs because of the kidney's failure to secrete proton or reabsorb bicarbonate, or the gastrointestinal tract loses bicarbonate as seen in diarrheal state, there will be one equivalent chloride reabsorption. When we lose one bicarbonate, we gain one equivalent chloride. Or when we retain one acid, we retain one chloride. The loss of bicarbonate is equivalent to the retention or gain of chloride. The serum anion gap, therefore, remains unchanged. These renal and gastrointestinal associated metabolic acidoses are referred to as normal anion gap metabolic acidosis. This brings us to the topic of RTA. So when do we consider the diagnosis of RTA? When we have a metabolic acidosis with a normal serum anion gap. If the serum anion gap is high, we can rule out RTA. The differential diagnosis for normal anion gap metabolic acidosis, however, include common causes such as diarrhea, pancreatic or biliary fistulas, ureteral GI connections, or renal tubular acidosis. How can we tell if the normal anion gap metabolic acidosis is due to the kidney's failure to maintain acid-base balance, known collectively as RTA, or if this normal anion gap metabolic acidosis is due to extrarenal causes, that is, causes that have nothing to do with the kidneys? This takes us to the calculation of urine anion gap. What is a urine anion gap? Similar to blood, all positive charges are equal to all negative charges in the urine. The major cations in the urine include sodium, potassium, and ammonium, where ammonium is essentially an acid that is being piggybacked by ammonia. The major anions in the urine include chloride and bicarbonate. These two quantities are equal. Rearranging the equation to place everything that we can easily measure on one side, we get the equation urine sodium plus potassium minus chloride equals unmeasured bicarbonate and ammonium. This quantity of unmeasured difference between bicarbonate and ammonium is defined as the urine anion gap, which can be estimated as urine sodium plus potassium minus chloride. Essentially, the urine anion gap gives us an idea of how much bicarbonate and ammonium we have in the urine. Under normal acid-base conditions, urine anion gap typically ranges between positive 30 and 50 millimoles per liter. How can we use urine anion gap to help us determine if a normal anion gap metabolic acidosis is due to the kidney's failure to maintain acid-base balance, or if it is due to gastrointestinal bicarbonate loss or other causes? This is our urine anion gap. If we have normal anion gap metabolic acidosis from an extrarenal cause such as diarrhea, normal healthy kidneys would do their best to compensate by reabsorbing as much bicarbonate as possible, making the urine bicarbonate essentially zero, and simultaneously secrete as much ammonium as possible, making the urine ammonium level very high. These two compensatory processes will make the urine anion gap very negative, because 0 minus a big number is a negative number. Bottom line, a very negative urine anion gap in a patient with normal anion gap metabolic acidosis reflects the fact that the kidneys do try to fix the metabolic acidosis by reabsorbing bicarbonate and excreting as much ammonium as possible. The underlying etiology is therefore extrarenal and likely due to conditions such as gastrointestinal bicarbonate loss. What happens to the urine anion gap if the kidneys cannot reabsorb bicarbonate at the proximal tubules? Here is the urine anion gap. Urine bicarbonate will be increased when the kidneys cannot reabsorb bicarbonate. Protons are still secreted and excreted as ammonium, but at a lower rate than that of bicarbonate loss. Urinary bicarbonate level will be very high compared to urinary ammonium level. The net effect is a very positive urine anion gap. Unlike extrarenal causes of normal anion gap metabolic acidosis such as diarrhea, where the urine anion gap is negative, proximal RTA will present with a positive urine anion gap. What happens if the kidneys cannot secrete protons and excrete these protons in the form of ammonium distally at the collecting duct? Here is our urine anion gap. Bicarbonate reabsorption is not affected, while acid secretion is very minimal. Due to the kidney's failure to secrete protons, ammonium level will be low. This means the urine anion gap will remain positive. In distal RTA, where acid secretion is reduced, the urine anion gap is positive as seen with proximal RTA. Putting everything together, we can entertain the diagnosis of RTA when we have a metabolic acidosis with a normal serum anion gap and a positive urine anion gap. Let's take a look at how RTA occurs. RTA occurs when the kidneys fail to either reabsorb bicarbonate or secrete hydrogen when kidney function is relatively normal. We do not and generally cannot diagnose RTA as an isolated disease entity in patients with advanced kidney disease because at advanced stage, all kidney functions will be reduced, so of course, tubular function in maintaining acid-base balance will also be affected. What are the different types of RTA? As you recall, bicarbonate reabsorption occurs in the proximal tubule. When metabolic acidosis occurs because of proximal tubular failure to reabsorb bicarbonate, we call it proximal RTA or type 2 RTA. Acid secretion predominantly occurs in the collecting duct. When metabolic acidosis occurs because of collecting duct failure to secrete protons, we call it distal RTA. Depending on the underlying etiology, distal RTA may be categorized as type 1 or type 4 RTA. Conditions that give rise to a mixture of both proximal and distal RTA are referred to as type 3 RTA. How does one get proximal RTA? Let's first review how bicarbonate is normally reabsorbed in the proximal tubules. Here we have proximal tubules. The first thing that happens is the secretion of hydrogen into the lumen. This occurs predominantly via the sodium-hydrogen exchanger, NHE3. Hydrogen combines with the filtered bicarbonate to form carbonic acid. With the help of the enzyme carbonic anhydrase, carbonic acid is split into CO2 and water. CO2 freely diffuses into the cell, while water crosses the cell via aquaporin channels. Inside the cell, carbonic anhydrase recombines CO2 and water to reconstitute carbonic acid. Carbonic acid then redissociates into a proton and bicarbonate. The proton returns to the lumen to pick up another bicarbonate to reabsorb, while the regenerated bicarbonate gets reabsorbed into circulation via the sodium bicarbonate cotransporter. Recall that most of the filtered bicarbonate is reabsorbed in the proximal tubules. Anything that interferes with any part of the bicarbonate reabsorption process can lead to reduced bicarbonate reabsorption and cause metabolic acidosis. Mutations, defects, or inhibitors of NHE3, carbonic anhydrase, sodium bicarbonate cotransporter, or isolated proximal tubular injury can lead to proximal RTA. Isolated mutation or defect of specific transporter leading to proximal RTA is rare. More commonly, proximal RTA occurs in patients with more generalized injury of proximal tubules from various causes. When this occurs, it is known as Fanconi syndrome. Recall that proximal tubular cells reabsorb almost everything. Because of this, patients with Fanconi syndrome may present with failure to reabsorb bicarbonate and develop proximal RTA, in addition to failure to reabsorb other solutes, including sodium, glucose, amino acid, low molecular weight proteins, phosphate, among others. Note, however, Not all patients with Fanconi syndrome develop proximal RTA. Fanconi syndrome may be seen in many inherited and acquired conditions. Inherited conditions are rare. Common acquired conditions include drug-induced proximal tubular toxicity and conditions such as multiple myeloma and Sjogren's. What kind of laboratory findings do we see with proximal RTA? The serum bicarbonate will be low, but typically 15 or greater. The reasons being, number one, once the plasma bicarbonate drops with the initial bicarbonate loss, there will be less bicarbonate to be filtered, therefore, less bicarbonate to be lost. That is, bicarbonate wasting is self-limiting. Number two, distal nephron segments can also compensate and increase bicarbonate reabsorption. However, if we infuse bicarbonate into these patients, the bicarbonate loss will pick up. Think of proximal RTA as an open sink for bicarbonate loss. The more bicarbonate is filtered, the greater the bicarbonate loss. Serum potassium will also be low in all patients with proximal RTA. The reasons being, number one, potassium is positively charged. It will follow the negatively charged bicarbonate loss in the urine. Number two, there will also be large amount of sodium loss, which will cause volume depletion and activation of the renin-angiotensin-aldosterone system. Aldosterone increases potassium secretion at the collecting duct. On urine analysis, urine pH reflects plasma bicarbonate concentration because this determines the amount of bicarbonate that can be filtered and lost in the urine. If we measure the urine pH while infusing bicarbonate into the patient to achieve bicarbonate level greater than 20, the urine pH will be high or greater than 5.5. However, if we leave these patients alone in the acidemic state with low plasma bicarbonate level, the urine pH will be low. If patients have proximal RTA due to conditions associated with Fanconi syndrome, mild degree of tubular proteinuria and glucosuria may also be seen. To diagnose proximal RTA, we need the following criteria: presence of a normal serum anion gap metabolic acidosis, presence of hypokalemia, because all patients with proximal RTA have low potassium level. The diagnosis may be confirmed by measuring the fractional excretion of bicarbonate after bicarbonate loading to achieve serum bicarbonate level of 20 to 24 milliequivalent per liter. A fractional excretion of bicarbonate greater than 15% with a concurrent urine pH greater than 7.5 confirms the diagnosis of proximal RTA. The fractional excretion of bicarbonate can be calculated as urine bicarbonate times plasma creatinine divided by plasma bicarbonate times urine creatinine concentration times 100%. How do we treat proximal RTA? Treatment of proximal RTA involves predominantly bicarbonate replacement. Because of the continuing loss of bicarbonate, the replacement dose is high and ranges from 5 to 15 MEq per kg body weight per day. Note: bicarbonate replacement can worsen the existing hypokalemia due to both renal potassium loss and intracellular potassium shift with alkalinization. Potassium replacement is given as needed. Vitamin D and phosphate replacement as needed in patients with Fanconi syndrome due to concurrent urinary loss of these substances. Finally, thiazide diuretics may also be used in some cases. Thiazide diuretics are thought to induce volume depletion, which could enhance proximal tubular reabsorption of bicarbonate. Note, however, the use of thiazide diuretics can also worsen hypokalemia. How does one get distal RTA? Let's review key points regarding hydrogen secretion in the collecting duct. Sodium is reabsorbed via the epithelial sodium channel known as ENaC. This generates a favorable electrochemical gradient for the secretion of potassium and hydrogen. The maintenance of this favorable electrochemical gradient requires removal of secreted potassium and hydrogen by a good urine flow, and removal of luminal hydrogen by ammonia as ammonium. An intact hydrogen ATPase is required for hydrogen secretion. And finally, aldosterone is a mineralocorticoid hormone that can upregulate the reabsorption of sodium and secretion of potassium and hydrogen. Distal RTA occurs when there is any problem with hydrogen secretion. Any one of the following can present as distal RTA. The use of ENaC inhibitors, such as potassium-sparing diuretics including amiloride and triamterene, or trimethoprim, a component of the antibiotic sulfamethoxazole trimethoprim. Poor urine flow seen with bladder urinary retention or obstruction of the urinary tract. Problem with ammoniogenesis. Factors or autoantibodies inhibiting normal hydrogen ATPase activity. Low aldosterone state, or inhibition or mutation of the mineralocorticoid receptor. Focusing in on alpha intercalated cells to see what else can interfere with hydrogen secretion to cause distal RTA. For every hydrogen that is produced and secreted, an equivalent bicarbonate is generated and reabsorbed. The generation of hydrogen and bicarbonate from water and CO2 requires normal activity of the enzyme carbonic anhydrase. While hydrogen gets secreted via hydrogen ATPase, the generated bicarbonate gets reabsorbed via the basolateral bicarbonate chloride exchanger. Inhibition or mutation of carbonic anhydrase or the bicarbonate chloride exchanger can lead to reduced acid production for secretion and reduced bicarbonate reabsorption and cause distal RTA. What can cause distal RTA? Unlike proximal RTA, where all patients present with hypokalemia, patients with distal RTA may present with hypo, normal, or hyperkalemia, depending on the underlying etiology. Distal RTA associated with normal or hypokalemia involves any defect within alpha intercalated cells that can lead to reduced hydrogen secretion. These include isolated defect of hydrogen ATPase, carbonic anhydrase, or basolateral bicarbonate chloride exchanger. Distal RTA associated with hyperkalemia may include aldosterone deficiency or resistance, anything that affects potassium secretion from principal cells such as ENaC inhibitors, or urinary obstruction that dissipates the favorable electrochemical gradient required for optimal potassium secretion from principal cells. One condition that deserves a special mention is distal RTA associated with diabetes mellitus. In some patients with diabetes mellitus, distal RTA may occur because of reduced aldosterone secretion. Hyperkalemic distal RTA related to reduced aldosterone activity is categorized as type 4 RTA. Reduced aldosterone in a diabetic patient may occur due to adrenal insufficiency or defect in the regulation of the renin-angiotensin-aldosterone system. The last form of distal RTA is associated with the use of the antifungal medication called amphotericin. Amphotericin is a multiplanar molecule that is lipophilic on the outside and hydrophilic on the inside. Because it is lipophilic on the outside, it can easily insert itself into the lipid bilayer membranes of cells in a collecting duct and form non-selective ionic channels for electrolytes to flow down their favorable chemical concentration gradient. Intracellular concentrations of potassium and magnesium are much higher than those in the urine, thus favoring potassium and magnesium leakage and wasting into the urine. Since the hydrogen concentration is greater in the lumen compared to that inside the cell, reflected by a much lower urine pH compared to that of plasma, hydrogen will leak from the lumen back into the cell in circulation. This hydrogen backleak results in metabolic acidosis. Amphotericin can therefore cause severe metabolic acidosis and electrolyte wasting. In an effort to minimize the development of metabolic acidosis and electrolyte wasting with the use of amphotericin, pharmaceutical companies have developed a formulation of amphotericin where the outside of the molecule is coated to turn the molecule lipophobic, thereby preventing it to self-insert into tubular membranes to cause metabolic acidosis and electrolyte wasting. This form of amphotericin is called liposomal amphotericin. How do patients with distal RTA present? Patients with distal RTA may present with more severe metabolic acidosis compared to those with proximal RTA. This is because patients with distal RTA cannot secrete the cumulative daily acid load from dietary intake over time. There may also be associated growth impairment, polyuria, and calciuria. Calcium deposits within renal parenchyma, known as nephrocalcinosis or stone formation in the collecting system, may also be seen. The easiest test to diagnose distal RTA is a 24-hour urine ammonium level. Ammonium comes from hydrogen and ammonia. High ammonium levels in the urine reflect high levels of acid secretion by the collecting duct. In patients with metabolic acidosis due to gastrointestinal bicarbonate loss as seen in diarrhea, the kidneys will secrete as much acid as possible to correct the metabolic acidosis. Because of the high acid secretion, the urine pH will be low and the urinary ammonium level will be high. On the other hand, in patients with distal RTA, where collecting ducts fail to secrete hydrogen, the urine pH will be high and urine ammonium level will be low. In patients with distal RTA and hyperkalemia, where ammoniogenesis is reduced, there is inadequate ammonia to buffer hydrogen. Whatever little hydrogen that can still be secreted ends up in the urine as a strong acid. In this case, both the urine pH and ammonium level will be low. If 24-hour urine ammonium measurement is not available, a clever test may be performed to diagnose distal RTA. In this test, a patient is given a bicarbonate load. In normal patients, as the bicarbonate is delivered to the collecting duct, it combines with the secreted hydrogen to form CO2 and water. The urine PCO2 level will increase and become higher than that in the blood. In normal patients, the difference between the urine and blood PCO2 levels will be at least 30 millimeter mercury. In patients with distal RTA, hydrogen secretion does not happen. CO2 is not formed. The difference in CO2 pressures between the urine and blood will be minimal. Another factor that determines efficient hydrogen secretion is the availability of ammonia. Ammonia, NH3, is needed to buffer and excrete hydrogen secreted by collecting ducts as ammonium NH4+. Ammonia is made from glutamine in proximal tubules as ammonium. After its production, ammonium undergoes recycling within the medullary interstitium before it gets secreted into the lumen of collecting ducts as ammonia. Inside the collecting duct, ammonia buffers the secreted hydrogen and excreted in the urine as ammonium. Ammoniagenesis is stimulated by low intracellular pH and hypokalemia and inhibited by hyperkalemia. Without ammonia, the secreted hydrogen will accumulate in the lumen and results in an acidic urine and hindrance for further hydrogen secretion. In patients with distal RTA associated with hyperkalemia, ammoniagenesis is reduced because hyperkalemia inhibits ammoniagenesis. Because of this, patients with hyperkalemic distal RTA can present with low urine pH and worse metabolic acidosis compared to those with normal kalemia. How do we treat distal RTA? We treat the underlying disease. Supplement with bicarbonate as needed. The required dose is typically lower than that used to treat proximal RTA because in distal RTA, we just need to neutralize the daily acid load, which is typically only 1 to 2 milliequivalent per kg body weight per day. We need a higher bicarbonate supplement dose of 5 up to 15 MEq per kg body weight per day in proximal RTA because those patients have continuing bicarbonate wasting. Last, we treat hyperkalemia with dietary potassium restriction and/or the use of diuretic as needed if patients also have volume overload for whatever reason. In summary, the function that is impaired in proximal RTA is failure to reabsorb all filtered bicarbonate, while function impaired in distal RTA is failure to secrete all the daily acid load. Defects involved for proximal RTA includes isolated defects in the sodium-hydrogen exchanger NHE3, sodium bicarbonate cotransporter, or carbonic anhydrase in proximal tubules, or more global proximal tubular injury with associated Fanconi syndrome. Defects involved in distal RTA include hypoaldosteronism, ENaC inhibition, isolated defects in hydrogen ATPase, the anion exchanger bicarbonate chloride, or carbonic anhydrase, obstruction of urine flow leading to the loss of the favorable chemical and electrical gradient required for hydrogen and potassium secretion, or hydrogen backleak, as seen with amphotericin. Note that problem with carbonic anhydrase 2 can lead to both proximal and distal RTA. The presence of both categorizes it as RTA type 3. In proximal RTA, the urine pH varies depending on the plasma bicarbonate. Urine pH is low in untreated metabolic acidosis, but as soon as we supplement bicarbonate, there will be urinary bicarbonate loss, thus increase in urine pH. For distal RTA, there is no or minimal hydrogen secretion. The urine pH is typically high, with values typically greater than 5.5. However, if ammoniogenesis is reduced in hyperkalemic forms of distal RTA, the urine pH can be low due to the loss of buffering by ammonia for any little hydrogen secreted. Plasma potassium levels are always low in proximal RTA, whereas it can be low, normal, or high in distal RTA. Distal RTA associated with hypoaldosteronism, ENaC inhibition, or obstruction can be associated with hyperkalemia, while all other conditions associated with distal RTA may present with normal or low potassium levels. The diagnosis of proximal RTA can be made with a fractional excretion of bicarbonate of 15% or greater following bicarbonate load. The diagnosis of distal RTA may be made by the lack of increase in urine CO2 after a bicarbonate load or by measuring 24-hour urine ammonium. Finally, in terms of treatment, patients with proximal RTA require a higher dose of bicarbonate supplement compared to those with distal RTA. At this time, you should be able to discuss the pathogenesis, diagnosis, and treatment for proximal and distal renal tubular acidosis. You should also be able to differentiate renal versus extrarenal causes of normal anion gap metabolic acidosis and diagnose and manage RTA. The end.